thank you for joining us for this first of a three-part webinar series on cancer care. And this is being done through the support of the American Cancer Society, as well as the PCPCC Center for Patients, Families, and Consumers, of which I'm a part of that. They have developed three different fact sheets and checklists to enable patients with cancer to better communicate both with their primary care and their oncology teams. And you can find those on the PCPCC website today. Having looked over those, I think they're incredibly valuable as we work with multiple teams and trying to provide the best possible care, both for the patient and for the family members. And so today I'm really excited about having the opportunity to introduce to you Dr. Amy Shaw, who is a family physician out of the Redwood Regional Medical Group in Santa Rosa, California. As I said before, you can access those checklists through the PCPCC.org website. And in addition to that, the recording and the slides from this webinar will be archived on the website starting tomorrow. And you can find all of the PCPCC's archived webinars under the Resources tab along the top of the website. There are a few announcements that I want to make for you. If you have any questions as we go along in Dr. Shaw's presentation, you can type those questions using the drop-down box on the top of your screen, and callers can ask any questions. And at the end of the session today, Tara will be reading those questions to Dr. Shaw, and she'll have an opportunity to answer as many of those as she can. It's a real privilege for me today, as a family member of a person with chronic illness, to be able to introduce Dr. Amy Shaw. She's a board-certified family physician with over 20 years' experience, and she recently left in 2011 private practice to focus exclusively on caring for men and women with cancer at the Redwood Specialty Clinic. She developed a primary care oncology practice that screens for and treats lingering and late onset effects of various cancer therapies. Dr. Shaw provides strong support for primary care providers in her community who want to remain closely involved with their patients throughout the cancer treatment continuum. She not only serves as a resource for other doctors, but also provides individualized cancer treatment summaries and survivorship care plans to each patient's primary doctor in order to communicate across care teams and improve care delivery as the patient transitions from cancer therapies into ongoing management of the patient's overall health and well-being by the primary care team. We are just thrilled to have the opportunity to learn from you, Dr. Shaw, and so at this point I want to turn it over to you and let you teach us. Thanks for being here.
Well, thank you, Brad, and thank you to the organizers of the Patient-Centered Primary Care Collaborative for inviting me. This is exciting for me. It's a good morning to you. I'm on the West Coast, and I think a lot of the people listening are throughout the country, so good afternoon to some of you. My talk, as Brad told you, is part of a larger discussion regarding the topic of primary care and its role in cancer, and we've divided cancer care into three sort of stages to make it easier to understand the processes involved. First, the stage is around the diagnosis of cancer, and the second, the cancer treatment stage, and thirdly, the long-term survival stage of cancer. I am going to be addressing this first stage, sort of the diagnosis stages, if you will, because this is the stage before a patient has started treatment for cancer, before the patient's care is mainly under the direction of the oncology specialist. The primary care physician has the most important role immediately prior to and at the onset of cancer care. Nobody else does this except the primary care doctor. Let me change slides here. What I'm trying to do.
Sorry, I believe it might be paused because it's changing on my screen. 1 second.
Okay. There's the slide. So this is me. You just heard a little bit about me. And I'm a family doctor who now works in oncology, caring for patients while in treatment and after treatment. But I also care for patients who are at high risk for cancer to do some risk reduction and also enhanced screening. I just want to point out, for those of you who don't do what I do, that I also don't feel that primary doctors need to become experts in oncology in order to help their patients, but they need to recognize their vital role in ensuring and understand that their patients get the best oncology care possible. In fact, I think they're integral to that. For some reason the slides aren't changing on my end. Are they changing on your end? There we go. I think it's important to revisit what we mean when we say primary care. Let me back up a little bit, get some slides back in order here.
Sorry, it's just running incredibly slowly for some reason. So,
all right, so let's go to that third slide with the
all right, so if you just
colorful picture.
I have it on the 5C, so I'll just be here as your highlight
all right.
if you want to.
Can I just say next slide, and that'll be easier?
Sure.
All right, let's do it that way. Okay, so this slide it sort of defines for me what I consider to be the primary aspects of primary care. And if you want a full description of what primary care is, you can go to Wikipedia for that matter, or the World Health Organization, and they have a pretty lengthy description of primary care and its importance and as a medical specialty and so on. I think all of you listening already understand the fundamental importance of primary care. But simply explained, I think primary care is basically first contact, continuous, comprehensive, and coordinating medical care, all of which are essential to providing high-quality cancer care. And I call these the 5 C's of primary care. First contact, because most patients initially present to their primary care doctors before being seen by specialists for a serious condition. Cancer certainly qualifies. This is continuous care, because primary care does not stop after a serious diagnosis has been made. Comprehensive care, because primary doctors oversee the screening, risk reduction, and disease management of these diseases, often in coordination with other doctors, and that's why coordination is also a key part of primary care. And, of course, care, because that is what we do best of all. Next slide. Well, that's changing. I just want to make clear that when I use the term PCP in my talk, I'm referring to all primary care providers, family physicians, general internists, pediatricians, and even mid-level practitioners that work in the primary care setting. So unless I state otherwise, I'm using this term PCP to refer to all those folks. It's a shorthand that some of us aren't comfortable with, but I'm finding when I'm giving a talk like this, PCP is just easier to say, so I'm going to use that. So just a quick review of cancer rates in America. This slide shows cancer incidence rates for women, particularly in the U.S., for over a 30-year time frame, starting in 1975 and ending in 2005. And as you can see, breast cancer has been the most common cancer in women during this time frame. But the rate has been dropping some since its high in the mid-1990s, and it's leveled off somewhat most recently. In 2013, it's estimated that about 805,000 women in America will be diagnosed with some form of cancer, and more than 1/4 of these will be breast cancer. This next slide shows men and their rates. Again, prostate cancer has been the leading cancer in men since 1975. And that's, you can see this big peak in the 1990s reflecting the onset of PSA testing. And in this year, about 855,000 men will be diagnosed with cancer of some sort, and about 1/4 of those will be prostate cancer. But it's important to remind everybody that lung cancer is still the leading cause of death for both men and women. And has been so for men since 1955 and for women since 1985. So next slide. So I'm going to move on now to the primary care role in cancer care. The next slide shows what we describe as the cancer care continuum. And cancer care is not just cancer treatment. So the slide comes up. In fact, if you look at cancer treatment, it's sort of the 4th box along the continuum here, this green box. And treatment is just one of many phases or steps along the cancer care continuum, which starts with cancer prevention, leads to early detection, goes to diagnosis, then the treatment for that cancer, and then survivorship after the treatment has been completed, then ultimately end of life, and either from cancer or another cause. It's these first 3 stages where primary care is so important, because the middle phase, or this green phase, is really where oncology comes in. So next slide, please. In fact, the important priorities of cancer services are affected by primary care: cancer risk reduction, as you can see here, early detection of cancer, or late complications of cancer treatments, timely access to specialist treatment, and overall support for the patient throughout cancer care. And those are really primary care issues, and that's why these first stages are so critical. Next slide. It's not unusual for a cancer's journey, a cancer patient's journey, or cancer patient's primary care doctor to be the only member of her care team that knew her before she had cancer. Patients will often say that their primary doctor is the only one who knew them, not as a cancer patient. And when patients and their families are asked about their preferences of having ongoing primary care during the cancer treatments, every study has shown that they absolutely want them involved. And this is a quote from one article that said, patients and their families believe there is an important and unique role for primary care throughout the cancer trajectory, starting from diagnosis and offering information and patient-centered holistic care. Nobody else on the healthcare team, or at least in the medical healthcare team, can provide this service. Next slide. So for today's presentation, I'm going to focus on the role of primary care providers during these first stages of the cancer trajectory, if you will, and that's the stages before cancer treatment begins. Next slide. So for ease of discussion, I've divided this presentation into three main areas, sort of primary care responsibilities before diagnosis, during diagnosis, and again after diagnosis, but before treatment. Next slide. So before diagnosis, primary care is really responsible for these three aspects of cancer care, which are absolutely important: cancer risk assessment, cancer prevention, and cancer screening. Let me go through these just so we all know what we're talking about. Next slide. So the first role of the PCP in the cancer care continuum is really cancer prevention, which starts with assessing each patient's baseline risk for cancer, what we call cancer risk assessment. Primary care doctors and providers are trained to do this from the beginning of their careers. We recognize that some patients have a higher risk than others for particular cancers based on a number of factors, including age, gender, lifestyle, and also there are some family histories that may suggest a genetic predisposition to cancers, and I listed a couple of them here, although there are more, but BRCA mutation carriers and Lynch syndrome in particular. So the next slide. So the role of primary care in cancer prevention is to counsel patients about how to eliminate or reduce modifiable risks, and when appropriate to consider an intervention that has been shown to reduce risk for cancer in certain patients with extremely high risks, such as chemoprevention in women at high risk for breast cancer, or prophylactic removal of tubes and ovaries in women at high risk for ovarian cancer, such as in BRCA mutation carriers. So these lifestyle changes are what primary care doctors discuss probably more than any other specialty in medicine today. Cancer screening is really so the test that we do to determine whether or not a patient has cancer, and in patients that have no symptoms. And essentially the primary care role in cancer screening is to make sure that the right patients are getting the right testing at the right time. Just a couple of remarks about screening. Certainly, as we all are aware, screening guidelines are constantly being updated as new information and new technologies are developed, and rather than fine-tuning these guidelines quietly, they're usually done publicly, and creates open-air debates that, in my opinion, seem to only drown out the message that cancer screening is indeed valuable. That as primary care physicians and providers, we need to use the right screening tools on the right people and to emphasize over and over that screening does work. And what's being fine-tuned is exactly who should be screened and when they should be screened and how we should, and what tests we should use to screen them. But the purpose of screening is still very valuable. So I think we need to really refocus the discussion back to cancer prevention and early detection. Okay, off my soapbox. Next slide, please. As an example of cancer screening and how we look at it, I wanted to show this age-specific breast cancer rate diagram, which illustrates pretty dramatically why we do not perform routine breast cancer screening on the average 35-year-old, but we certainly should be screening every single 70-year-old woman. And this is exactly why. And I show this slide a lot to my patients because the perception in the community is that the woman with breast cancer is usually age 40, and the 75-year-old woman thinks she doesn't need to get mammograms anymore. If you look at the risk of breast cancer in these different age groups, there's quite a large discrepancy here. So next slide. I want to turn over to the primary care role in the diagnosis of cancer. Next slide. So there are two important responsibilities that primary care has with respect to cancer diagnosis. And the first is making the timely diagnosis, and the second is informing the patient of the cancer diagnosis. The cancer is found in one of two scenarios. After screening tests for asymptomatic patients, that's a surprise. No one expected it. The patient had no symptoms. That's the shocking phone call that says your mammogram was not normal, or your colonoscopy that found a tumor. Or cancer is found after a workup for suspicious symptoms in symptomatic patients. But in both these scenarios, primary care physicians are essential. So in these asymptomatic patients, as you see here, primary care has almost exclusive role in ensuring that asymptomatic patients get appropriate and timely cancer screening, as I already mentioned. And again, there's this continuous debate about the value in reducing mortality in certain populations of patients, but we know that screening does find cancer. Next slide. So although more and more patients with cancer are diagnosed from a screening test ordered by their primary doctor, but for those patients whose cancers are actually found after they present with a symptom, 80% of those are actually still turning up at their primary care doctors as well. So let me explain that again. For patients who don't have symptoms, their cancer is found through their primary care doctors. And for those who do have symptoms, 80% of those end up in their primary care doctors as well. So the workup for these symptoms falls primarily on the primary care provider. Next slide. So these are symptoms that may be subtle or and nonspecific, symptoms that are in fact often poorly predictive of cancer, such as fatigue or low appetite or body aches. These are complaints that patients bring every day. Of course, the vast majority of patients that are telling us of these symptoms do not have cancer. And the differential diagnosis list may be extremely long indeed, but the workup generally falls on the primary doctor because they are trained to evaluate symptoms. As I say to my specialist colleagues almost on a daily basis, our patients present with symptoms. Their patients present with diagnoses. It's up to the primary providers to find the diagnoses that are recognized through the symptoms. So there's no other specialty that requires such a wide-ranging knowledge of the seemingly infinite number of diagnoses that any constellation of symptoms might ultimately indicate. It is our job as primary care providers to elicit a full history, perform an appropriate exam, and then, when warranted, order appropriate testing or refer to an appropriate specialist. And all of this, of course, in a so-called timely fashion. Our level of suspicion is determined after our thorough history and physical, and so on and so forth. These asymptomatic patients who are ultimately determined to have cancer regard this initial encounter with their primary care provider and then subsequent workup leading to the cancer diagnosis as the most important part of their entire cancer experience, because they understand that the stage at cancer diagnosis is the most important determinant of survival for practically all cancers. So if they feel that this was a bad experience, if there was fumbling and delays in getting workup or coordination of getting testing, the patients feel like they can lose trust in their primary care doctors, and the patients become hypervigilant for the remainder of their care. And this goes out through many, many years of treatment, and every time there's a point of having to change course of treatment, the hypervigilance comes back. I think we've all seen this, but what studies have shown, and some of my experience has taught me, that this hypervigilance often starts at the very beginning when the first initial presentation happens and the patient felt like things were not taken seriously. So I want to throw that out there. I think my primary doctor friends know this very well indeed, and it's a hard balance to maintain. Next slide, please. So now that the cancer diagnosis has been made, it's the primary care provider's role and duty to inform the patient of the cancer diagnosis. So the responsibility to inform a patient about a cancer diagnosis generally falls on the primary care physician. I haven't seen any published research on this, although I've looked, but based on my conversations with many physicians over the past 20 years, the vast majority of them, in fact, I have not met anyone so far, but the vast majority of them prefer to inform their own patients about a new cancer diagnosis rather than deferring this to a radiologist, a surgeon, or other specialist, especially if the primary doctor was involved in the initial workup for this cancer, which they generally were because of ordering the screening test or working them up. How do patients feel about hearing a diagnosis from a primary care doctor? Well, research has found that they prefer it to any other specialist talking to them. But having the primary care doctor having them nearby is reassuring for the patients. They want them involved. But delivering bad news is not easy. I think we all know this is probably one of the hardest things we do in the healthcare field, more than anything else, and some of us are better at it than others. But it is a skill that can be learned, and I'll talk about that more in a moment. But it's safe to say, as Beckman said in 1992 in a very important study looking at how to deliver bad news, he said, if we do it badly, the patients or family members may never forgive us, but if we do it well, they may never forget us. And this is true. This is the first step for them about cancer, and they remember the moment they were told. So bad news in cancer. There are 2, sometimes 3 important times along the cancer care continuum when so-called bad news will be delivered. The first is at the time of diagnosis, and for some patients there will be a second time when the cancer has recurred, or there will be a third time when the treatment has failed and hospice is being considered. The patient's primary care doctor may be involved at all of these steps, but the first step is one that will likely fall exclusively on the shoulders of the primary care provider, so at the time of the initial diagnosis. So let's talk about how to deliver this news. The next slide describes a technique you already may be made aware of as a sort of communication technique or mnemonic for delivering bad news. And I actually use this. I don't go about it so systematically anymore, but I sort of make sure that all these parts have been taken into consideration when I'm going to give somebody bad news. Sometimes even if it's on the phone, you can do this. So when you're preparing to give a patient bad news, it is important to keep in mind a number of issues at the same time that will make the experience better for both you and the patient. And S.P.I.K.E.S stands for these things you see here, the setting, the environment, perception, invitation, so on. I'm going to go through these one by one. So the next slide is setting, the environment. And next slide, please. So setting the environment in which the bad news is delivered. It's important that there's a private space. This can't be out in the open. It can't be in a waiting room. It can't be in the hallway. It's important that everybody's introduced at who's ever around, who's part of the conversation. You want to make sure all the appropriate people are present. The spouse is there, the children are there, whoever the patient wants around there. You want to make sure everybody has a place to sit, and you want to ensure that there's no interruptions while you give the message. You don't want any pagers going off. You don't want any knocks on the door. So your staff should know what's going on in the room, and they can leave you in privacy. The next slide shows the importance of perception. It's important to know what the patient's perception is of what they think is going on before you launch into what's going on. Because sometimes they know very little, sometimes they know a lot, and you can use that as sort of the beginning of your conversation. And that's why it's important to sort of understand and ask the patient, so tell me what you know so far, starting with that conversation. The next one is I for invitation. The next slide. So after you have given the information, you want to always ask the questions to invite the patient or anybody else in the room into conversation, and ask how much information the patient actually really wants to know, so you can know how much detail you need to go into. And often what they want to know is what are the next steps. So the next slide shows the K for knowledge. And this is how you deliver the message. This is key, and this is the thing that, and the part of the whole process which you just have to practice and get very, very comfortable at doing. And one is use very plain language. And you have to get to the point very clearly. Be mindful of your own body language. Give information in small chunks, and then pause. Because after you said you have cancer, there's this incredible deafness that sets in. Anything you say after that will not be heard. And so then you want to wait for the reaction. And once things have settled down, then you sort of may repeat yourself over again. I think everybody listening to this webcast this morning already has done this, and you're all recalling certain experiences where it went well and probably where it didn't go so well. And sometimes you can pinpoint later on why it didn't. And sometimes I'll use the sort of teach-back technique to verify the message was received and saying, can you explain to me, please tell me how much you understand and what you think the next step is and what I said to you so we all understand that. E is for emotions. By that, we want to be prepared for the patient's and family's emotional response as much as you can be. And you want to anticipate, of course, the fear, anger, sadness, denial, and guilt. All these things come out at once and by different people in the group there. You want to also be very mindful of your own responses. And you don't have to agree with the patient's emotional response in order to validate it. You know, I can see that you're very angry. I can see that you're upset. Whether their reasons for being upset are valid to you or not is irrelevant. It's more that you can just validate they're having those emotions. And then obviously comfort the patient. But this needs to be appropriate to the patient's culture, their age, and their gender. And this is the care of the primary care. And lastly, the next slide is the final S in Spikes, and that's strategy and summary. You want to assess the patient's readiness for planning, negotiate what the next steps are, verify the support structure, answer any questions. If you don't know the answer, say, I don't know yet, but I'll find the answer for you and get back to you. And then summarize what the next step is. You know, use the teach-back technique again. Say, this is our plan. Do you understand our next step will be this? Have a follow-up plan when you're done. You've given the patient bad news. That's part A. Part B is now saying what you're going to do about it. So now the patient has a diagnosis, and before treatment, primary care's role continues and steps up considerably. So next slide. This is a critical function of primary care and usually requires the assistance of support staff, lots of support staff. And some of these are functions that can and probably should be delegated to support staff. Patient navigator, if you have one in your office, you have access to one. A nurse navigator, perhaps if you have one in your community. Some people have them in their offices. Definitely your medical assistant, your referral person, whoever you have in your office who helps you with the coordination of care, because that's where you need to coordinate care to the specialty groups. This is also the time when shared decision-making regarding options comes up, and the primary care doctor acts as a very safe sounding board for shared decision-making. I'll discuss a little bit more in detail. Advocacy is key, making sure the patient gets what they want from whom they need it, and from whatever facility that they're getting it from, whether it's getting lab results, getting x-ray studies, getting things scheduled. The support staff can be extremely helpful in advocating for the patient in these other systems. In fact, I think they do it better than I as a doctor. That's my personal belief. Primary care's responsibility at this point is also to manage patients' comorbidities. Patients rarely have just cancer. And those other comorbidities need to be addressed and maximally treated, including mental illness, depression, and anxiety, which clearly have probably been ramped up by this. And then psychosocial support. Make sure the patient has in place their support team, their families involved, and who they claim is their network of supporters. So I want to go into a couple of these in a little more detail. And the next slide is a little bit more about coordination of care and the cancer care team. Now, as you can see, the cancer care team can be huge, but luckily most patients won't require this many specialists during their care, although sometimes they do. But the patient's primary provider must be sort of central to that team and sort of have contact with all the different specialists. What can happen, as you know, is the primary care doctor refers the patients to medical oncologists. Medical oncologist refers them to radiation oncologist. Radiation oncologist refers them to physical therapists and so on. And the coordination gets out of the reach of the primary care because each specialist is referring further and further down the line. That's not a problem as long as you are kept in the loop as a primary care provider. And this requires conversation with your own specialists about making sure that you are always kept in the loop when other members of the care team are added on and become integral to the patient's care. Sometimes I sit down and just write down for the patient all the different specialists they've been seeing and all the places they've been going for care, and it is astounding. I think I've had one patient who had a list this big. So shared decision-making is an essential function of primary care providers, and by this I mean primary care physicians. Regarding treatment choices, you want to be sure to read the oncologist's consult notes, and if the reasoning for the recommended treatment is not laid out, then a phone call to the oncologist is in order so you understand it. It's important for a patient's primary doctor to understand why a patient will be having a certain course of treatment as much as it is for the patient and her family to understand that. Your job is not necessarily to tell them what they should do, but to help them understand why it is being recommended. So I consider this to be an essential primary care physician function. and it really cannot be delegated to non-physician staff. This is a doctor-to-doctor conversation that you then share with the patient. Sometimes the primary care provider needs to be just sort of a sounding board for the patient, and sometimes they need to really help the patient make very difficult decisions that may require you to get more material, another consultation. Maybe the patient really needs a second opinion. This is where the patient comes in and starts sharing with you all the stuff that's come up for them. And you also want to make sure that the patient's most important co-decision maker, their spouse or their best friend, is in the room during this discussion. Because patients will usually defer to this other person after your conversation with them and ask them what they think. And even they had this long conversation about it and came to some conclusion, the friend may disagree, and then everything starts over again. So you want to have the most important decision maker, co-decision maker in the room when this conversation happens. Next slide. So some challenges that might come up during a discussion about treatment options include the ones that I list here, the ones I've seen. I'm sure you all have as well. One is limited comprehension of the language of medicine. Some patients really don't have an understanding of the concepts of biology and human anatomy and science and statistics, and yet when we talk about cancer, we're talking about all of these things. And statistics plays a major role. We talk about the risks and benefits of various treatments, the relative risk of improvement, the absolute benefits, the 1 out of 10 chance of this, the 15% that, and this is information for patients that's completely foreign to them, and yet they're asked to make a very, very difficult and perhaps life-saving decisions on this. So you really want us to understand how much the patient has comprehension of these basic concepts. There's also cultural barriers that may come up about how much patients want to know and how they want to be told. Family dynamics certainly play a role. In one patient, the patient may want something else, but the family member might decide on another course of treatment. And then there's the misinformation from friends and family and internet, all from well-meaning friends and family, I might add. The next slide. So it's misinformation in the web. It's not surprising that research has confirmed that cancer patients are among the most active users of the internet. 60% of cancer patients and their companions routinely use the internet to search for information. And of course, this is a good answer. Physicians have to be experts in physicians have to be sort of the information and misinformation and myths out there on the internet, and correct all of these misinterpretations or on the medical research. And they want to do this all while trying to not insult the patient's intelligence. At the same time, we want to support their desire to be proactive in their care. So let me try to reiterate that a little bit more clearly, that one of the challenges is to understand that what is the truth, what we understand clinically and scientifically about a treatment, and what the misinformation is out on the internet about perhaps what that treatment does or doesn't do, or about an alternative treatment. And at times I have to go onto the internet myself and read about these bogus treatments so that I can tell the patient, yes, I understand what you're talking about, I've read that, and let me assure you that that is not safe or that has not been studied. In fact, there is studies that show it's not effective. And then I gain some credibility from the patient because I've actually read that as well. My God, there's so much junk on the internet, it's scary. If you want to know what the gold standard of care is for treatment of a particular cancer, you can go to the website nccn.org. You can look up standard of care, gold standard protocols for screening and treating almost any type of cancer. These are free. These are the references that oncologists use. Primary care doctors may want to look at them too. They also have great information for patients, and patients can go on here. So if you want to know what the standard of care is for the treatment of thyroid carcinoma, you go on here, you look up and go, here's the standard of care as of 2013. These are being updated continuously. So I use these a lot. I give these to patients who have the knowledge and interest in reading about it, so they know that this is the standard of care. No textbook will be as up-to-date as this will. So I recommend this website. Next slide. So primary care role after diagnosis includes psychosocial support, and very, very importantly, it's no surprise that a cancer diagnosis brings a mix of reactions. Listed here, disappointment, fear, hopelessness, and guilt comes up a lot. This is where patients re-examine their diagnosis in relation to past life experiences, stressful events, and very bad habits. This is a lung cancer patient who now has been smoking, and all the guilt that comes up around that. Also, you can see an exacerbation of pre-existing mental illness, in particular post-traumatic stress disorder. It can be re-energized, I suppose. Depression and anxiety disorders are also clearly exacerbated by this, and so expect to have to jump in and really help manage these as best you can. So I want to stop for a moment and really look at this term good medical care, and I struggle with this because we all try to pursue good medical care, and what is good medical care when it comes to cancer care, and what is good medical care from patient's perspective and from the doctor's perspective. And when I looked at a definition of good quality medical care for early diagnosis of cancer, I found a lot of different explanations. So I want to just share with you two. One is the standard Institute of Medicine definition, which is good medical care is defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Well, that sounds good. And I think we all know what that definition means. I'm not sure, whatever that means. And that's the problem with that one. It can be interpreted in so many ways. So I don't like that one. But what I like is this one. Here's the definition of good medical care from a group of cancer patients I interviewed a couple of years ago. I have a patient focus group at my clinic, and I sort of bounce things off of them. They're my sounding board. And I asked them to define good medical care for me, and this is what they came up with. Care that is individualized and provided by competent, non-judgmental, compassionate doctors and their staff who listen, communicate clearly, and follow up when they say they will. And I think we all know what that definition means. So when I talk about good medical care, this is really what I want. This is what I try to focus on, and this is sort of my compass. And it certainly plays out in cancer care. So what is the best model for primary care to provide optimal or highest quality cancer care? I have to say there is no clear winner. Patient-centered medical home holds probably the greatest promise. Whatever the model of care, though, the patient's primary care doctor will still need to remain closely involved, or else optimal cancer care will not be realized. Patients told us they need individual care. They need somebody to help monitor them and manage them throughout their cancer continuum. And so my final advice, and I know I sound like a nagging mother, but an occasional phone call to our patients asking them how they are doing is tremendously valuable. And patients have told me over and over again they are so appreciative when their primary care doctor just calls them and says, I'm just checking in and seeing how you're doing. I see that you just had your surgery. I see that you're in the middle of chemotherapy. I see that you're almost done with this. And, you know, because every time they get a consult note, they pick up the phone and call their doctor. And patients love this, and I hope the primary care doctor recognizes how valuable that is for them. So that is my basic talk, and I want to thank you for your time. I'll take any questions you might have, but if you would like to email me later with a comment or question, my email address is on the next slide, and I will open this up to any questions.
Thank you, Dr. Shaw. That was a great presentation. I just wanted to apologize to everyone. We are having a little technical difficulty with the slides, so thank you for remaining patient and staying engaged. We do have one question, but for those of you on the call, you can type in your questions. There's a little tab that you can type in your questions, and I'll read them as we get them. So one of the callers was interested in how health information technology improves the process. Does it play a role as you're coordinating the care between the teams? You further expound upon that.
It helps if all the providers. It helps if all the providers are in the same system, and if all the providers put in the accurate information. I mean, health information technologies don't fix the problem of garbage in, garbage out. For example, I have many patients who are they're in different systems. I take care of patients in a Kaiser system and patients in non-Kaiser systems. They come to me forever. And a lot of them come to me with their electronic records, and I can tell you there's no summary in there of their cancer treatment, for example, even though this was all within an integrated system. Patients don't even know what all the drugs they got. So I think it's some of these health information systems provide a wonderful opportunity for there to be improved coordination of care and less fragmented care, but somebody still has to be in charge of making sure it happens. Otherwise, you just have fragmented silos of care within a larger health information system. It hasn't changed it. The patient doesn't experience it as collaboration. Certainly, if you're looking for test results, that's useful. Say, well, I see so-and-so ordered a test. Let me go find that for you. And that solves that problem. But making sure doctors are actually talking to each other, I'm not sure how that health information can facilitate that. Sometimes just a phone call totally makes up for it. I mean, patients will tell us, and I think if you had cancer yourself, you understand this. Anybody who's listening, you hate going to a doctor's office, you see a specialist, somebody else refers you, and that doctor has no idea who you are and why you're there, doesn't have your most up-to-date records, or you were just there 2 weeks ago and they don't even know why you're there. You feel like an idiot, and it's like, what am I doing here? I'm wasting this person's time. Or I just answered this person's questions yesterday, and now I'm asking them. So, and this person may be sitting in front of a computer the whole time, so everything is on the computer, and yet somehow the patient still feels like no one's paying attention, no one's listening. So going back to my definition of what quality care is, it's really that, individualized, one-on-one, making sure a patient gets the care they need, and somebody needs to be in charge and put it all together. I don't know if that totally answered the question. So I think health information systems hold promise, but they still need somebody to shepherd the patient through the system and be in charge.
Thank you. We had a question kind of to piggyback on that, is that how do you stay in communication with the oncologists and the other specialists to facilitate that continuity of survivorship care?
So for survivorship care or any cancer care, I use all methods. I talk to them at tumor boards if I'm seeing there. I email them after I've seen their patients. I'll pick up the phone and call them. I even text a couple of times. Some of them I text. It depends which doctor, and sometimes entirely by communication through notes. So it depends. If I need to let them know what's going on with the patient right away, I will usually pick up the phone and call them. And I try to get inside lines for all the doctors I work with. I try to get cell phone lines for everybody. If I can quickly get on the line and talk to a doctor on a cell phone, that takes 3 seconds out of my day, takes 3 seconds out of their day. If I have to leave a message with their medical assistant, it takes everybody's, it takes 10 minutes on everybody's part. So oftentimes it's one-on-one. And in my notes, my consult notes, and my notes to these doctors, I will spell out, very clearly, and usually in lay terms, what I'm concerned about or what needs to happen or some of the next steps. And it's very clear. Every one of my notes has at the very bottom that coordination of care. The patient will see the following person for the following reason at the next note, and I spell it out. But I stay in contact through all these different ways with the docs. And it's what I did as a primary doctor, too. When I was taking care of these patients from the other end, I would refer them out, and if I didn't understand something in the consult note, I picked up the phone and called the doctor. If I saw something that concerned me, I'd call the doctor, and I usually would then call the patient. I don't know, good old-fashioned phone. I use the phone. So.
Great. And another question we had was, what are your thoughts on clinical staff reaching out to the patient? In addition to you, this person wrote, stay involved, stay in touch. Does it always have to be the physician who reaches out to the patient?
No, absolutely not. It's a great question. Some patients will bond very closely with certain members of the staff. There might be a medical assistant or an RN, a patient navigator, for example, who's connected with the patient very well, and they'll contact the patient on a regular basis. They just checking how you're doing. And, my medical assistant does this routinely for a lot of my patients that I don't call, but she does, and she'll tell me how they're doing, and then the patient feels comforted to know that basically when she calls, she's calling on my behalf. So yeah, it's patient by patient. Some patients really, you connect with them in different ways, and so some staff will do that. I had, at my previous office, there was a receptionist who connected really well with a couple of patients, and she would call them and see how they're doing, and then she would tell me how they're doing. And then I, once in a while, call a patient. So yes, I invite the staff to remain involved, because these patients are cared for by a group of people, and we all play a role.
So how do you encourage patients to remain engaged with their primary care team? So after cancer diagnosis and treatment, oftentimes it's difficult for patients to remember to go back to their physician. How do you recommend oncologists encourage patients to go back to their primary care doctors?
Well, yeah, there's ambivalence on the primary care doctor's part as well as that wanting them to come back, because there's, you see this. The patient's going to doctors every 2 days practically. It's like, well, why do I want them to come in and see me? I'm not as important, which is not true. If a patient has any comorbidities, which 93% of breast cancer patients do, whether it's hypertension or diabetes or arthritis, that should be a reason for you to see the patient on a regular basis. And sure, that's going to be an excuse for seeing them. I want to see you every 4 months so I can keep an eye on you and make sure everything else is working fine, that you're getting the care you need. And you make it sort of a routine during the course of your treatment. Or I want to see you at the end of your radiation to check in and see how you're doing. And you can set these sort of goals for the patient, like when you're done with this, I want to see you for that. Or because you have this, I want to see you for that. So I actually have patients try to schedule with their primary care doctors along the way. If that's not possible and the patients don't want to do it or their care is someplace out of town, then just a regular phone call will work. What I'm working on a lot in my community is trying to get the oncologist to send the patients back to primary care. Because what will happen is, as you've seen this, everybody's seen this, the oncologist treats the breast cancer, the patient has hypertension. Next thing you know, the oncologist is treating the patient's hypertension. They go, oh, look at their, I'm going to add this hypertensive med. It looks like you're getting early diabetes. Here's some metformin. And next thing you know, the oncologist is the internist. And the patient feels there's no role for a primary care doctor, so next time she gets a cold, she goes to her oncologist. And that's not correct. The oncologists really recognize that they are subspecialists. And these patients do best, as studies have shown, do best if their primary care doctor remains involved. And you'll hear another presentation next week or coming up in the next couple of weeks about the role of primary care in survivorship after treatment. And the studies are very clear that patients who remain closely involved with their primary care doctors do better, less mortality, less morbidity, and mortality is from cancer is not changed, but mortality from non-cancer causes is much less. So patients with the history of cancer are less likely to die of heart disease, for example, if they stay involved with their primary care doctor. No surprise there. Primary doctors are good at health promotion and prevention, especially around heart disease. So it requires proactive actions on part of the primary care to get their patients to stay involved with them, but also the oncologists need to let the strings out a little bit more as well.
So given that it seems like everyone operates on a different sort of HIT platform, how quickly should the exchange of information occur between primary care and the specialist?
Well, if the patient has, for the initial referral, should be as rapid as possible that day. And when I give a patient a diagnosis, I have already, before I even give the patient the news, I've already made arrangements for the patient to see, for example, the breast cancer. I've already made an appointment for the patient to see the breast surgeon or a breast surgeon, and I have that in hand, and the breast surgeon already has at least a copy of the pathology report. So when the patient comes in, I sort of give them the bad news on one hand, but on the other hand, I give them the plan, and here it is, and and you don't have to make any phone calls. I've already made you an appointment. If this doesn't work for you, let me know. If you want to see somebody else, I will reschedule you to somebody else. But this is the plan right now, and patients are and their families are so grateful that they go, okay, the next step is already here. I don't have to do anything about it. So very rapid referral to that very first consultation. Now, cancer, most cancers, the exception being leukemia, more than any, most cancers are not emergencies. The workup should be done quickly, certainly, and as I mentioned earlier, mainly more for psychological reasons. And the referral to the first specialist should be done promptly, also for psychological reasons. But once the doctor or the patient's in the doctor or subspecialist office, then there's time to sit down and plan. What are we going to do about this? And so I try to push as fast as I can to get the patient to the specialist with all the right information, and then we can slow down a little bit. And I do point that out to them. So the first step is to get you there as quickly as possible, and then we start planning. It's like getting you into the place where you can start building your house. Now we work on how we're going to build it, or use whatever metaphor makes sense. But anyways, so that's how quickly I get things to it. Sometimes it's a handwritten note. I will write a note. Patient has new diagnosis of blah, blah, blah. I'll send a copy of their problem list with it, and then they'll get a dictated note later on. Now, for folks who have electronic health records where you can just push a button and out prints the most recent H&P, that's extremely helpful. I still dictate. I still have notes that have to be transcribed. A little old-fashioned that way.
In regards to cancer screenings, what guidelines do you follow?
Oh, yeah. Kind of whatever one I'm in the mood for. The American Cancer Society guidelines are probably the most liberal or conservative, however you want to define that term, recommending, for example, breast screening starting at age 40 annually up until whenever. And then the United States Preventive Services Task Force, of course, recommends no routine screening before age 50 and then every other year after that, based on risk factor analysis. And that's why I put in my presentation risk assessment is probably key before risk screening, before cancer screening. You need to understand a patient's risk before you understand how to screen for them. I've seen patients with BRCA mutations go and get a routine screening mammogram, which was appropriately ordered, but then the radiologist has a note back, come back in 2 years. It's like, well, no, this patient comes back in 6 months for an MRI. But so we have to understand, and if you didn't know this patient had a BRCA mutation, or if then the radiologist didn't, then the patient's going to get the wrong information. So you need to know what the patient's risks are for whatever cancer you're screening for, and that determines the frequency of the testing and what testing you do. I mean, the highest risk breast cancer patients, mammogram plus MRI, that kind of thing. And for the lowest risk patients, just mammogram is probably every 2 years, starting at age 50. Colon cancer screening is kind of going through a review. This colonoscopy really isn't good as we all think it is. Only 16 to 17% of patients who need it actually get it. So it may be a great test, but it's not being widely applied. And patients are, I've never met a patient that looks forward to her or his colonoscopy. But fecal occult blood testing, if done annually, is probably just as good if your goal is to reduce the death rate from colon cancer. But in high-risk patients, fecal occult blood testing is not enough. You need to do colonoscopy. So there's a long answer to your question, which is you need to apply it to each person based on their individual risks. And don't forget about risk prevention. Like as I said, 40% of cancers are probably based on lifestyle changes. These are modifiable risk factors. So rather than focusing so much energy on screening for cancer, if all we did was really fix the risk factors we already know that we can fix, 40% of cancer would not be around. That has greater impact than any other drug or any screening test out there. I mean, no screening test reduces the incidence of cancer by 40%. Screening tests are intended to find cancer early enough in the stage where it's potentially curable. That's the whole point of a screening test. It doesn't prevent cancer. That's why getting mammograms does not prevent breast cancer. I've seen that you see these billboards everywhere, get your mammogram, prevent breast cancer. Which, wait a minute, has nothing to do with that. Get your mammogram and lower your risk of dying of breast cancer. But that's not a good soundbite.
So taking the conversation back to patient-centered medical homes, what are some components that you use in your practices to like really incorporate and coordinate care? For example, do you use huddles with the staff to increase internal office communication about the different patients?
Yes, absolutely. Now I work in a setting that has a very small group. So our huddle is me and a medical assistant and my front staff, and I have a patient navigator. So it's 4 of us. By all means, every day we look at every patient who's coming in, and we look at their issues that are going to come up. We look at stuff from the day before and bring up any sort of new issues. But we also, because I work now in cancer exclusively, we also do an emotional check-in on how we're all feeling, making sure we're all doing okay. Because we have patients. I do have several patients that are on hospice, and this is something the staff needs to deal with just like I do. We connect with these patients, and and we lose them, it's sad for all of us. So my huddle also includes sort of a quick check-in, an emotional check-in. And if one person's saying, I'm having a hard day, we all know that would support that person. So that's also the value of check-in. It's just keeping the team strong and healthy emotionally so we can give better care to patients. So yeah, I can't imagine not huddling, not doing the huddling. I mean, you have to. It's like you have to orient yourself. Otherwise, you'll start the day off lost.
So you mentioned about dealing with the patient's emotional needs, and so how do you address a patient or a family members that are in denial about a specific diagnosis or even mortality?
How do I deal with it? I deal with it very gently. This is not, unfortunately, a rare occurrence. And the denial comes from fear and trying to understand the fear behind the denial. And sometimes I'll elicit from them a history of what their experience with cancer is, and invariably you find a story about, their mother died of cancer in this terrible scene, or they had some experience in their childhood or in their youth where cancer was just the worst thing that ever happened to them ever. And so learning that they have cancer almost exhibits a post-traumatic stress disorder. And sort of understanding that and really dealing with the fear of it. And I just work with them a lot. I try to break their denial down slowly without breaking them down. But it's a process, and you kind of want to just hit them over the head and say, "What are you dumb here? You're going to die if you don't do anything." I mean, there's that my emotional reaction of worrying that their treatment's going to be delayed so much that it's going to affect their life, and sometimes it is delayed, and sometimes it does affect their life. And they deny they have a breast lump until the breast lump is growing through their skin. I can't fix that. But I can tell you that the patients that are in the greatest denial are those that come in by themselves. And if a patient comes in with a family member, if the patient is exhibiting any denial, it's going to go away. Because the family member there is there to support the patient. And they don't want this person to die. So I'm always worried when a patient comes in by themselves. Because it means they don't have enough support, and that means they may not follow through. I want to end with just something I've learned as part of my practice. Since I take care of patients with cancer at all levels, from those who don't have cancer and those who have advanced cancer, when I think about quality of life for these patients, I think about different domains of quality of life, and all of us have these. We just don't think about them. One is the physical quality of life, our spiritual quality of life, our emotional quality of life, our family, friends, community quality of life, and then there's the physical aspects of, do we have a roof over our head and food on the table? And with cancer, it's just one aspect of quality of life because it affects your physical health, how you feel medically in your body. But these other aspects of the quality of life may be quite rich. You may have a rich spiritual, family, community life, and so on. And so what I will see is sometimes as patients' health deteriorates from cancer, these other aspects will grow. But the patients that come to me with these other aspects already impaired, no community involvement, no family, no support, no spiritual background or thing, then when their cancer becomes a problem, they decompensate in every way, and denial becomes more of an issue with them. So this is sort of something I've sort of observed through my years of doing this. So just an observation.
Well, Dr. Shaw, I want to thank you for your time and giving this presentation. It was a much-needed discussion, and we had a lot of great feedback that I'm seeing that people typed in that are very appreciative of your presentation and what you are doing, this innovative model that you're doing out in California. I do want to remind everyone that we will be posting this recording and the slides to the website. You can access them on our website at www.pcpcc.org. We have the 3 fact sheets, the checklist that we developed. So we hope you can take some time and check those out. And we thank you for all your questions. If you have more, Dr. Shaw did leave her email address. You can see it on the slides. So thank you, everyone.